Welcome to today's episode of the VJHemOnc podcast. We're focusing on two important precursor conditions in hematologic malignancies: clonal hematopoiesis of indeterminate potential, CHIP, and clonal cytopenia of undetermined significance, CCUS. Both conditions are increasingly recognized as early warning signs for the development of myelodysplastic syndromes and acute myeloid leukemia. In this episode, we'll explore the latest research on CHIP and CCUS, the challenges in identifying and managing patients with these conditions, and the ongoing debate over whether and when we should intervene. To begin with, we hear from Professor George Vassiliou, speaking at this year's Intercepting Blood Cancers workshop, who highlights how our understanding of clonal hematopoiesis has advanced in recent years. This is followed by Dr. Sanam Loghavi, who discusses the advances made in identifying individuals with CHIP and CCUS, while also emphasizing the ongoing challenges, especially when it comes to patient management.
We've learned a lot about clonal hematopoiesis. You remember the phenomenon was fully captured in terms of its genetic background, let's say, in 2014, 2015. So we've had about 10 years of learning. We've learned that clonal hematopoiesis is a very long, let's say, phenomenon that a single cell grows steadily and slowly over years. We've learned that the different gene mutations can drive the expansion slowly or more fast. We've learned that aging can change the rate at which clones expand. In fact, certain clones do not expand at all when you're young. Other clones seem to not expand when you're old. But we've also learned that certain mutations have a high risk of progressing to malignancy and others don't. We've learned that the clone size increases the risk of malignancy. And primarily, we have learned that this phenomenon is really common, and we have ways of identifying those who are high risk and low risk. And why do I say primarily? Because we needed this in order to start targeting treatments, interventions, preventive action to those individuals. And the other big development in clonal hematopoiesis is its large number of associations with non-hematological diseases: cardiovascular disease, lung disease, kidney disease, bone disease, etc. And clonal hematopoiesis has now moved into the realm of many medical specialties. You know, as a clonal hematopoiesis, let's call myself expert if I may, but as someone who works very intensely with clonal hematopoiesis, I get contacted by all sorts of specialties trying to understand what clonal hematopoiesis does in their specialty. So there is a whole lot of new information. I mean, there's still a lot to learn, which is great news, because we love doing research, we love understanding, we love treating, we love preventing. But we have learned a lot, and I think we've moved from somewhere where we didn't know, should we be treating, should we be interfering, to somewhere where we are poised to do that. So it's quite exciting, and I look forward to the next few years.
The field of CHIP and CCUS is a rapidly evolving field. And, I would say in the last few years, we have learned a lot about the biology of CH and CCUS. And we've also developed a lot of new and novel technologies that are able to detect clonal cytopenia of uncertain significance or clonal hematopoiesis that are more readily available and that are being used more often, such as, in the context of patients with solid tumors, the use of liquid biopsies. So we're identifying these patients at a much higher frequency than we were before. And this really provides us with the opportunity, but also a lot of challenges, because we detect these abnormalities in patients, yet the field has not really caught up in terms of, how we manage these patients and how we manage these entities with our knowledge of the biology of disease. So, a few of the clinical scenarios that we're going to discuss in the workshop today are really distinguishing clonal hematopoiesis from mosaic germline genetic mutations, such as, the case of mosaic leaf-Rameni syndrome, from clonal hematopoiesis with TP53 in a patient that's being, worked up for a solid tumor and is incidentally found to have a high VAF TP53 mutation. The other is distinguishing genetically high-risk clonal cytopenia of uncertain significance, meaning CCUS that has either multiple mutations or mutations that are in the genes that are known to be of higher risk, or, several mutations together, and then distinguishing that from what is thought to be a phenotypically low-risk disease, right? Low-risk MDS. So if we catch the patients early enough, they're not necessarily going to be very cytopenic, right? Because cytopenia develops over time, but they may have genetically high-risk disease that we know is destined to become high-risk MDS. So that's the other challenging scenario. And then the third, I would say not as much challenging, but, intellectually intriguing scenario is the identification of donor-derived clonal hematopoiesis in patients that are recipients of allogeneic hematopoietic stem cell transplants.
Now let's dig into some of the progress that has been made in the understanding of CHIP and CCUS. Professor George Vassiliou outlines the key mutations that are frequently found in these conditions. He is followed by Dr. Mrinal Patnaik, who explains the two categories of clonal hematopoiesis, age-related and context-relevant, shedding light on how these subgroups differ.
There is about 10 to 12 genes that drive the vast majority of CHIP and CCUS. And the most common ones are DNMT3A and TET2, and ASXL1 is the third most common. But these genes are actually beginning to appear in the population as drivers of clonal hematopoiesis as early as from the ages of 30 or 40. They increase in prevalence with age. They seem to, in isolation, carry a moderate risk. Particularly DNMT3A carries, I would say, more a low risk, apart from hotspot mutations in the RAT2 position of the gene. TET2 is a slightly higher risk. ASXL1 is slightly higher still. But as a group, they are not very high-risk mutations, these, but they are the commonest. When you look at some of the less common mutations, like mutations in JAK2, for example, they are high-risk mutations for progression to myeloproliferative neoplasms, which they themselves are not as difficult a disease group as acute myeloid leukemia or myelodysplastic syndromes to manage. So even though it's a high-risk gene, the disease that develops is not so aggressive. Then a CALR, another gene, which not very common in clonal hematopoiesis, but goes with JAK2, does the same thing. But there is another group of genes, the splicing factor genes, SF3B1, SRSF2, and U2F1, those are high-risk genes. When we see the clones driven by these genes, we see that they expand fast, and the risk of progression is also very high. So those genes, I think, could be ones to target in preventive interventions, but at present, we don't really have many targeted therapies for these genes. Another couple of genes are the P53 gene and the PPM1D gene. P53 is a gene that we do see in myeloid malignancies, but we're still learning about the risk because heterozygous mutations in P53 do not look to carry a big risk, but homozygous mutations do. So it's another interesting area where there may be future intervention. And another looking at clonal hematopoiesis from a broader context, we know that in certain scenarios, for example, individuals with telomere biology disorders, aplastic anemia, and people who have had chemotherapy, the types of clonal hematopoiesis are different. So we're learning a lot about how to understand and capture and modify clonal hematopoiesis in those individuals. So a whole lot of new insights, a whole lot of learning, and generally a very exciting field to be in.
Yeah. So, as the last decade has progressed, we've understood that clonal hematopoiesis is clearly segregated into two subtypes. The first being age-related clonal hematopoiesis. These are large population-based studies that have been done. These are seen in aging individuals. They have a low risk of progression to hematological malignancies, have associations with cardiovascular disease and other comorbidities. But in academic medical centers, what we more frequently encounter is what I refer to as context-relevant clonal hematopoiesis. So these are clonal hematopoiesis or CHIP mutations that arise in the hematopoietic stem and progenitor cells in response to things that are happening in the individual's body, such as other tumors, more importantly, therapies for the tumors. These are genotoxic agents, they're radiation-based therapies or radioligands. They can also be seen in individuals who have, hereditary problems causing bone marrow failure or increase their risk for leukemia. So they develop a very unique spectrum of CHIP mutations. These mutations are highly relevant because unlike the age-related clonal hematopoiesis, these tend to progress much quicker, causing hematopoietic dysfunction and a very dangerous outcome, which is therapy-related myeloid neoplasms. So these are conditions such as acute myeloid leukemia, where treatment responses are quite poor and the morbidity and mortality are very high.
Next, we turn to Dr. Susan Slager, who shares insights from a recent study exploring the relationship between monoclonal B-cell lymphocytosis, CHIP, and the subsequent risk of developing both lymphoid and myeloid malignancies. Dr. Anton Langerak will then discuss the potential for early interception in MBL.
MBL and CHIP in the prior studies have looked at each one individually. We're the first study to look at both of them simultaneously. So we had a cohort of 10,000 individuals that we screened for both MBL and CHIP. And what we found is that the two precursor conditions are independent of each other. So there's no relationship between MBL and CHIP. Next, we went and looked at the association of each precursor with incident lymphoid malignancy. And we validated what prior studies have found, that having an MBL increases your risk of getting lymphoid malignancy about 4-fold. And then if you had CHIP, especially CHIP in one of the genes that are related to lymphoid malignancy, you also have a 4-fold increased risk of lymphoid malignancy. So these are findings that have been previously found, and our study is validating those findings. But what our study is unique is that we're able to look at both of them simultaneously. And so we looked at the interaction between MBL and CHIP for risk of lymphoid malignancy. And what we found is a synergistic interaction. What that means is that individuals with both MBL and CHIP have almost a 7.5-fold increased risk of lymphoid malignancy. This is compared to individuals with MBL only, so no CHIP, they have a 3.5-fold increased risk of lymphoid malignancy. And individuals with CHIP only, so no MBL, have just under 2-fold increased risk of lymphoid malignancy. So there's clearly a synergistic interaction between CHIP and MBL. When we looked for myeloid malignancy, we didn't see that interaction. And so regardless if you have MBL or not, individuals with CHIP have an increased risk of myeloid malignancy on the order of 6.5-fold.
Based on the data that we have obtained, I think it's too early days for that, for a couple of reasons. We just starting to, I think, understand what the different genetic and protein landscape is in those early stages. And I think what we need to do is clearly define the ones that are really at high risk of developing progression into CLL or lymphoma for that matter. So I think based on what I've shown, yes, there could be potential for thinking that direction. But then really if we use those data for defining high risk groups. But still, I think in MBL, as opposed to, for example, in myeloma, smoldering myeloma, or maybe even with CCUS, I think it's a bit difficult to see how this would evolve, knowing that the aggressiveness of the disease is different, such that it will take longer before it finally develops into a malignancy. And so, yeah, there's another balance to be taken there, or consideration to be made on the anxiety of starting to treat versus the benefit of that treatment.
One of the most debated topics in this space is whether or not to treat individuals with CHIP or CCUS. Should we intervene early, or is a watch and wait approach the best course? Professor George Vassiliou returns to make the case for treatment, arguing that early intervention could prevent disease progression. Dr. Mrinal Patnaik follows with key considerations for treating these entities, as well as looking towards future directions in managing precursor conditions.
Yeah, so it's a very legitimate question. Individuals with CHIP or CCUS are generally well. They don't have any symptoms, and many of them will remain asymptomatic for the rest of their life. So it's a legitimate question as to why are we treating these individuals? Why do we want to interfere? And now the reason that I believe we should be interfering, we should be working to prevent progression of these individuals is because the conditions they progress to are nasty conditions, and many individuals will not survive those conditions. So there is a proverb that says prevention is better than cure, but in this case we don't necessarily even have the cure. So certainly prevention is much better than no cure. Now, why are people a little bit hesitant is because of the concept of giving treatments to individuals that are well. I can perfectly understand that. But of course, we've learned a lot over the last few years about the behavior of the precursor conditions, clonal hematopoiesis or CHIP and CCUS. We know that they are slow developing conditions. They may take years to progress. And we're not thinking in terms of aggressive treatments that will be given to healthy individuals. We're thinking of subtler treatments that will stop the progression. That is, as I said, a very lengthy process. So overall, I think we have enough to consider treatments. We, of course, have to adjust them to ensure that they're largely side effect free, they can be tolerable, and people can take them for longish periods without many problems. So I feel strongly that recent advances have also identified such treatments that can be given without major toxicities. So I think we have reached the point where we should be doing clinical studies, because we've never done clinical studies or trials in this context.
So do I believe the answer is yes? Are we there to do it right now? The answer is no. So I do think that, some of the CHIP or CCUS precursors that we understand are high risk for evolution into blood cancers are the ones where early detection and interception play a role. The vast majority of CHIP that you see in aging individuals are not going to progress to leukemia. How they interact with other comorbidities, including heart disease, needs more, definition. And especially if treatments have elements of side effects, you do not want to make the cure of disease more grievous than the endurance of the same. But this higher risk population where progression, is likely to happen over the next several months, if we can detect them and we can intercept, whether it's with medications or, different modalities such as vaccines against, the mutations, immunotherapy, I think that would be a dream come true, hopefully in the next few years.
That wraps up today's episode on CHIP and CCUS as precursor conditions in hematologic malignancies. Thanks for listening. We hope you found it insightful. Don't forget to follow us on X at VJHemOnc and subscribe to our podcasts on Spotify, Apple, or Podbean. Until next time.